All right, this is a review over the first portion of the nervous system, including the introduction lecture talking about neurons and synapses, as well as the cerebral cortex and some subcortical areas of the brain. So this is our first whiteboard, just showing a neuron. So the neuron in the middle in the purplish color is our neuron of reference, okay? The basic parts of a neuron. So obviously in the middle we have the cell body. So these extensions coming into our cell body are called dendrites. Okay, our little connections here with these presynaptic neurons are synapses, right? So these would be considered presynaptic. This would be considered postsynaptic. Then off the cell body we have this long extension called the axon, okay, which may or may not be myelinated. The axon then splits into axon collaterals, right? So this neuron could be synapsing with one neuron, it could be synapsing with thousands of neurons, depending where you're at. And then we have synapses here. So now our neuron, or the neuron of reference, is the presynaptic neuron for these two neurons, which would be now postsynaptic. This means whether it's before or after a synapse. So if it's myelinated, so myelin's a lipid-based substance made of mostly lipid and some protein. And this is a great drawing here of a transverse section of an axon. You can see the myelin just wraps around like a jelly roll. The cells in the peripheral nervous system that make this are called Schwann cells. The cells that make these myelin stuff in the central nervous system are called oligodendrocytes. Have fun with that one. Okay, and we'll come back to that in a second. So our neuron, so this is number 55 is a threshold voltage. So at rest, our neuron is polarized at negative 70 millivolts. So for our neuron to send an action potential, we have to reach a threshold of negative 55 millivolts. So at rest, the neuron is at negative 70 millivolts, and that is our resting potential. That's our resting potential. So for our neuron to send an action potential, we need to hit a threshold of negative 55 millivolts. So we're going to have excitatory neurons here, drawn in green because green means go, and inhibitory neurons, so drawn in red because red means stop. So when we have excitation from our excitatory neurons, they send things called EPSPs, or excitatory postsynaptic potentials. So they're excitatory as postsynaptic, so it's after the synapse. Potential, and anything referring to potential, remember that means like a charge or whatever, okay? So what happens here is basically sodium channels open and positive charges move towards the cell body. So positive charges are going to take a resting potential of negative 75 millivolts and make it quote unquote less negative, is how the textbooks put it, meaning bringing it closer to the threshold of negative 55 millivolts and closer to zero, like less negative. Now, inhibitory neurons are like off switches. So these can actually pump positive charges out or can push negative charges in. So let's just say, for an example, negative charges in, you can see chloride ions moving in. Well, if more negative charges are moving in, well, that could actually hyperpolarize the neuron and move the charge even farther from threshold. So if resting potential is negative 70 millivolts, a bunch of negative charges move in, we could go to like negative 75 millivolts, almost hyperpolarizing it or keeping it further away from threshold. Either way, if we want our neuron of reference to send action potential, there has to be more EPSPs than IPSPs, meaning more excitation than inhibition to get that charge up to negative 55 millivolts. And then the sodium potassium pumps, stop pumping everything out because sodium channels open. So voltage gated sodium channels that open at negative 55 millivolts, that's their voltage that they open up at because they're voltage gated. Sodium rushes in, rushes down the axon like a domino effect to all of its collaterals, and then our neuron will excite or inhibit these neurons, whatever its job is to do. Okay, and then when we repolarize, we hit up to about positive 30 millivolts, and then voltage gated potassium channels open, potassium ions leave, and that starts the repolarization process back to the beginning. And again, we're not going to have to go over all those individual steps of all that stuff. So myelin, coming back to that, so myelin, we talked about this, is made by Schwann cells in the peripheral nervous system and oligodendrocytes in the central nervous system. So what does it do? It wraps around the axon. There's little gaps in between areas that are myelinated. And what it does is it increases conduction speed. So action potentials up here, they're all or none. You either hit threshold and send one or you don't. They're not weak or strong, okay, but they can be faster or slower. So what two things can make an action potential faster? One's myelin. So if we have a myelinated neuron, okay, we're a myelinated neuron, the myelin's only going to be on the axon, not the dendrites, not the cell body. And a thicker axon. The thicker, bigger the axon is, the faster it can be. Now, how is it slower? So unmyelinated neurons, when there isn't myelin on the axon, it'll be slower, and then also thinner axons. So myelinated neurons send action potentials faster. So an example of a disease that affects myelin is multiple sclerosis. So multiple sclerosis, this is an autoimmune disorder, and it actually damages myelin. So if it damages motor neurons, they become unmyelinated, or the myelin isn't functioning properly, and you have motor deficits. If it affects sensory neurons, you have sensory deficits, and then if it affects some places in the brain, it can have cognitive deficits. And the most worrisome from the motor standpoint is when the nerves affecting the diaphragm, like the phrenic nerve, is affected, and it can affect breathing. Okay, so the synapse is far more interesting than action potentials. At least it's my opinion. So the synapse is right here. So between the presynaptic neuron here and the postsynaptic neuron here, we have the synapse. So how this works is an action potential is coming down this presynaptic neuron, sodium channels are opening, and we get to the end of the neuron. This isn't drawn here, but voltage-gated calcium channels opening. Calcium moves into the end of the neuron. And calcium is the ion that's responsible for stimulating these vesicles here full of neurotransmitter to migrate towards the end of the neuron and then dump their contents, the NT, the neurotransmitter, into the synapse, which is then going to bind to receptors on the postsynaptic neuron. Okay, so to say that again, remember sodium and calcium, again, to back it up even way beyond this system, remember, your primary two extracellular cations are sodium and calcium. So if you open a channel to sodium or calcium, guess what's going to happen? Sodium and calcium, depending what channel opens up, is going to rush in, right? Sodium and calcium want in, and potassium wants out, to put it a very basic way. So anyway, calcium channels open down here at the end of the neuron. Calcium rushes in. So these are vesicles full of whatever neurotransmitter this nerve has. So there could be dopamine, it could be serotonin, or whatever. And it's going to stimulate them to dump their contents out into the synapse, and they're going to bind to receptors. And then all neurotransmitters have their own receptors. It's not usually more than one. Like dopamine has a D1, D2 receptor. Glutamate has a series of NMDA receptors. Serotonin receptors, usually 5-HT receptors. There's a few of them. Okay, and then it'll either have an excitatory or inhibitory effect on this postsynaptic neuron, just depending where it's at and what's going on. Now, to clear the neurotransmitter, there's two ways, right? So if we want to shut this down, well, the action potential stops firing from the presynaptic neuron, but we have to clear up all this neurotransmitter. And this is super important because there's so many drug targets at the synapse that you're going to learn pharmacology. So you might as well learn about some right now. So how we clear the neurotransmitter. So the main way is reuptake, right? So we've learned about reuptake before, and we even talked about this with, well, we'll get back to that later, but reuptake, so the neurotransmitter goes back up into the presynaptic neuron. And also anything that's left, there's enzymatic breakdowns. There's enzymes in here that'll break down some of the neurotransmitter. We already talked about acetylcholinesterase breaking down acetylcholine at the skeletal muscle. And today I will talk about an enzyme called monoamine oxidase, or MAO. So monoamine oxidase breaks right here. Monoamine oxidase breaks down catecholamines, right? Well, what are the catecholamines? Dopamine, serotonin, norepinephrine. So this one enzyme will break down all three of those. Okay. All right, so let's talk about some neurotransmitters. So dopamine. So what's dopamine used for? So it's in certain parts of the brain. It deals with the reward pleasure pathway. So we talked about this, like the nucleus accumbens area. So like ventral tegmental area, nucleus accumbens, and how that deals with reward and pleasure, and how that can actually lead to addiction. So motivation. So when dopamine levels are healthy, in a healthy range, people feel motivated to get up and do things. And it makes more sense to explain this when dopamine levels are I hate to say crash, but dopamine activity is low. And then movement. So the movement's the funny part. So what does that have to do with reward, pleasure, motivation, all this stuff? Well, this has to do with the neurons in the basal ganglia, right? The caudate nucleus, globus pallidus, putamen, substantia nigra. So we have a bunch of heavy density of dopaminergic neurons there, and they deal with refining movement, which we'll get to later, okay? Now, what happens if dopamine signaling is low, or there's a decrease in dopamine activity? You don't want to say like low dopamine levels are high. You don't really want to say it like that because it's not necessarily always true. But people get anhedonia, which means a lack of pleasure. So anaerobic, like lack of oxygen, anhedonia, hedonic or hedonism means like a pleasure, a pleasurable, whatever. Um, so people get lack of pleasure in things they should get pleasure in. So, relationships, food, you know, getting an A on a test, whatever, you should get a burst of dopamine. Be like, I feel good. That just felt good. Or even pick up your phone and playing on Instagram. You might get a little burst, tiny burst of dopamine, right? And obviously, illicit drugs, sex, so on and so forth, can all cause a spike in dopamine. But you don't get that level anymore. Okay, and we see this in addiction as well. Someone just bombards their postsynaptic neurons with dopamine, like people with take a high dose of cocaine, let's say. Cocaine will reverse the reuptake of dopamine at the reuptake channels. And if you take enough of it, it'll just make the presynaptic neuron basically just puke out all of its dopamine and just dump it all at one time on the postsynaptic neurons. What happens is the postsynaptic neuron, well, right away it's going to start adapting. That's why no high is better than the first high, because right away your brain will start adapting. Your brain's very good, or say your nervous system is very good at adapting to certain drugs very quickly. We'll see this. This happens with alcohol. This happens with opioids. This happens with psychostimulants like cocaine, which can make things sometimes difficult. But in this case, so it becomes less sensitive. So the D1, D2 receptors are less sensitive to dopamine. The postsynaptic neuron can actually pull receptors off itself, so there's less receptors. So guess what? When that dopamine high goes away from the drug, then people they start getting this feeling of anhedonia. I don't feel good, right? I don't get pleasure or anything. And then they want that dopamine back, right? But then again, if you keep taking that drug over and over again, well, it's like almost the postsynaptic neuron's almost kind of resistant to dopamine in some way. You could say that, like we talked about insulin resistance before. It doesn't have enough of a effect, right? So there's less of an effect on your brain because the postsynaptic neuron's not being excited as much as it was initially. So you might need a higher and higher dose of drug, or just enough drug just to get you through the day and just be, quote unquote normal. All right, serotonin isn't as complicated, so it deals with mood and your sense of well-being. So mood is if you're happy, you're sad, you're joyous, melancholy, however you want to say the different moods. I don't know them. And a sense of well-being, just a feeling that everything's taken care of, everything's handled, your bills are paid, school's going good, work's going good, relationships are good, whatever. So when there's low serotonin activity, people get a poor mood, and the opposite of feeling like everything's put together is things are not put together, and they can get almost feelings of anxiety. All right. Now, the last one, norepinephrine, not last one, of the catecholamines, norepinephrine. So this stimulates wakefulness. When you wake up in the morning, there's an area in your brain called the locus ceruleus. It releases some norepinephrine, wakes up your brain like a cup of coffee. And it also increases psychomotor activity. Psycho meaning how fast your brain's working, motor how fast you're moving. So in those people, they have stimulants, Adderall, amphetamines, methamphetamines, cocaine, or just caffeine, right? Or even nicotine, they're all stimulants, right? They increase norepinephrine levels in your brain. So if someone's a cup of coffee, they might not even notice it, but they're talking faster, they're moving faster, might be gesturing more. When someone's tired, they're not talking as much, they're not moving as much, right? So that's norepinephrine. So if you have decreased signaling in norepinephrine, that causes fatigue. So we see this, someone who was on psychostimulants like cocaine or methamphetamine, that's upregulating norepinephrine like crazy. Then you take that stimulant away, their norepinephrine activity goes way down, and they just can feel exhausted. Okay. So all these three are also implicated, the catecholamines, in symptoms of major depression. So obviously, if you had issues with dopamine, having anhedonia of lack of motivation, well, that could make someone feel, quote unquote, depressed, right? These are symptoms of what depression is, right? Serotonin, so low serotonin activity, so poor mood and anxiety, also can be some symptoms of depression. And then fatigue. So this is when someone can't get out of bed at all. So it's different from lack of motivation. Low dopamine, I have no pleasure. I don't feel like doing anything. I just don't want to do it. I don't want to go there. I don't want, you don't want to do anything. Nothing feels good. Norepinephrine, if you've ever known with severe depression or clinical depression, is sometimes they go through those bouts where they literally physically cannot get out of bed because they physically feel exhausted. That's the difference between norepinephrine and dopamine. Okay? So we have all these fancy drugs, right, for depression. So from MAOIs to SSRIs to SNRIs to NDRIs. So the bottom ones here we'll talk about first. So SSRIs are selective serotonin reuptake inhibitors. SNRIs are serotonin norepinephrine reuptake inhibitors. And NDRIs are norepinephrine dopamine reuptake inhibitors. So what these drugs do, they all have a similar mechanism of action. Although they affect different neurotransmitters, they block the reuptake. So by giving someone an SSRI, you're not increasing the amount of serotonin they have. Right here at the presynaptic neuron, they're blocking the reuptake of serotonin back into the presynaptic neuron. So if serotonin hangs out in this space for longer, it has more time to interact with the receptor. So there'll be more postsynaptic neuronal activity because it's just interacting with the receptor more. It's going to bind to the receptor longer or more, or however you want to put it. And that's how SNRIs work, just with serotonin and norepinephrine. That's how NDRIs work with norepinephrine and dopamine. Okay. Now the other drug that's a different mechanism or different target is MAOI. So MAO is monoamine oxidase. It's the enzyme that breaks down dopamine, serotonin, norepinephrine. So if we inhibit if we inhibit this enzyme, well, guess what? Dopamine, serotonin, norepinephrine will hang out for longer in the synapse, and there'll be more dopamine, serotonin, norepinephrine activity. That sounds fantastic. So, question a lot of people ask is, why don't you just give everyone an MAOI? Why give an SSRI and just get serotonin? I want all three because that'd be awesome. But the more neurotransmitters you start allowing to hang out in the synapse longer, the more risk for side effects. So obviously, something like an SSRI is going to usually have lower side effects than an MAOI, which aren't used as often because their side effect profile. Okay. Oh, not yet. Okay. In the previous slide, we did talk about glutamate and GABA. Sorry, I skipped over that slide. So yeah, glutamate is the main excitatory neurotransmitter in the brain. GABA is the main inhibitory neurotransmitter in the brain. So those are pretty much global, right? They're almost everywhere in the brain. Where dopamine, serotonin, norepinephrine, they're more localized to more specific areas for the most part. So glutamate's the main on switch or the main excitatory neurotransmitter. GABA is the main off switch or inhibitory neurotransmitter. So you have a balance between GABA and glutamate activity to how excited or inhibited your brain is. So we see this in people with epilepsy. They might have one area of the brain that's malformed, whether from birth or they've had an accident, had a TBI or whatever. And then that one area of their brain, or sometimes just globally in their brain, it gets overexcited, meaning too much glutamate activity, it can lead to a seizure, right? Whether it could be a small tic type thing where people have with like Tourette's, or very small like absent seizures, or it could be something like a full-blown tonic-clonic seizure when someone, loses consciousness and has, tonicity, clonus, like they're just contracting their muscles really hard. So it's overactivity of glutamate, okay? So we see that there with glutamate and GABA, so drugs that affect that. Alcohol is a big one because alcohol is a quote-unquote depressant. So what it does, it decreases glutamate activity, but it upregulates GABA activity. Okay, so you start drinking, that's what happens. So when someone starts drinking every day, well, and they're drinking more and more and more, well, your body, again, your nervous system adapts right away. It's like, okay, you're blocking all this glutamate activity. So guess what? I'm going to put a bunch of glutamate receptors up, and the glutamate receptors become really sensitive. You keep increasing all this GABA on us. It's way too much GABA. I'm going to become less sensitive to GABA. And that's where you get the situation where someone can drink a case of beer every day or a whole fifth of liquor, and they're up walking around talking and like, they're not like, obviously dead of alcohol poisoning. So their brain gets more adapted to it so they can stay more aware and more, their brain isn't as inhibited by the alcohol as someone who's alcohol naive, meaning someone who doesn't usually drink. They go and drink a case of beer, obviously they're going to be severely inhibited. Okay, so that's what happens, right? And then the big thing that you guys have to know as nurses, well, that's great to know, but what happens when you take the alcohol away? Someone's been drinking for years and years and years daily, and you pull the alcohol away from their brain, right? Because this is affecting their brain. So you're going to have these patients in the ER, you're going to have these patients on the floor, going through alcohol withdrawals. So when you pull the alcohol away, well, there was like hardly any glutamate trickling in their brain, so so now they've become super sensitive to glutamate. You pull this depressant away, now all the glutamate comes trickling back, right? All the glutamate comes trickling back, and they have way too much glutamate activity. What happens? They get agitated, they get tremors, they can have a seizure, and they can even potentially die. That's why on CEWA protocols, we give the patients Ativan. What does Ativan do? Ativan binds to the GABA receptor and increases GABA activity. It's why these benzodiazepine drugs like Ativan, Xanax, Valium, midazolam, which is Versed, what they can do, they kind of bring your brain down, slow your brain down, calm things down, because that's one thing that they're used for anxiety. Midazolam is used for as an anesthetic drug for amnestic and calming properties. But with CEWA protocol, we give Ativan to increase GABA activity to make sure these patients they're not as agitated, and also make sure they don't have a seizure and die. Moving on, okay, brain. So cerebral cortical areas, okay. So remember, this is a great drawing. It's awful. So your cerebral cortex, right? So this is the cerebrum, cerebral cortex, however you want to put it. This is the conscious part of your brain. We saw this on pictures of slides. This is like the outer the outer shell of your brain, like the cortex of a bone. The cerebral cortex, the outer shell of your brain, which is made of gray matter, and it's just full of tons of neurons. And we have all these areas programmed into it. So the frontal lobe goes all the way through this area here. So the frontal lobe has the most to talk about here. So frontal lobe, parietal lobe's back here with the somatosensory stuff. Occipital lobe is all the visual information coming in, and the temporal lobe has all of our other special senses, and this is important for speech and language. So the frontmost part of the frontal lobe is the prefrontal cortex. The prefrontal cortex job is impulse control. So when we get to the limbic system, we'll talk about this. The limbic system is important for keeping you alive. Okay, so very primitive type part of our brain where we get potential aggressive behaviors, violent behaviors, sexually potentially inappropriate behaviors. So our prefrontal cortex controls our impulses, right? And humans, as a mammal, we have a much larger frontal lobe, especially this area, than any other species. So this kind of helps us allows us to hopefully control our impulsive behaviors. Or some other mammals don't have to do that or shouldn't do that to survive. So prefrontal cortex impulse control, last part of our brain to develop, usually about the mid-20s. Most people quote the age 25. And sometimes people say it's the first part of our brain to start degenerating because our brain atrophies as we get older. And so that's why younger people tend to this is very big, very large generalization, tend to do more impulsive things or have more impulsive behaviors. And then this is why sometimes people who are aging, the aging brain, people tend to say more inappropriate things. Not necessarily saying they have Alzheimer's or, like frontotemporal dementia of any kind, but just saying they have, that brain, part of the brain's not working quite as well. So they kind of lose that filter and they say inappropriate things like, I always say the same thing. The grandma that says, looks at someone and says their ass looks fat in those jeans. Well, hey, grandma, you can't say that to anybody. But they go, oh, they're old, they don't care anymore. Or maybe their prefrontal cortex just isn't working quite as good as it used to. I always use the same example because it's perfect, right? And this has been studied a lot more recently. Again, I talked about in class how there's a neurologist who's been going to all like state penitentiaries and prisons and doing functional MRI scans. So remember, the brain, we used to only be able to study it by like, hey, this person has this disease or they're in this category or that category. Let's wait till they die, cut their brain open and look at it. That area looks bigger or smaller of this form or that form, but it didn't tell us about the activity. We already know, your brain can't just get bigger and bigger and bigger. So you can't just form new neurons as an adult because you got to skull, and it can't keep getting bigger. Like your bicep can keep getting bigger, right? But there's room for it to grow, but there's not really room for your brain to grow. So a lot of what we see, parts of your brain can be developmentally a little larger or a little smaller. They can atrophy. So that is a value, but also how active they are. So um, we have to look at like a functional MRI, put some in an MRI machine, show them images, and try to stimulate those parts of the brain and see how active they are on imaging. Okay, so how metabolically active they are is what's important. They might not be bigger or smaller, but so this neurologist did this, and he showed these, all these inmates who had a high level of recidivism, meaning they kept going back to jail over and over again. Why do they keep committing crimes? Well, are there any differences in their brain? He wanted to know, and what he saw was a lot of their prefrontal cortices, their prefrontal cortex, was underdeveloped. Meaning, if your prefrontal cortex isn't developed right, you're gonna have a real hard problem with impulse control because those signals from the limbic system are gonna come into the brain. You're gonna have a hard time slowing those down. Okay, the rest of the frontal lobe here, or the frontal cortex proper, we can sum that up as higher cognitive functions. So doing long division, reasoning, problem solving, deciding to do the right thing when the wrong thing's easier or whatever, all that kind of stuff. So limbic system fires signals to prefrontal cortex, it catches it to control the impulses, and then we kind of mull it over in our frontal lobe. Behind her, we have the frontal eye fields, help moves the eyes. I'm not really going to go over that. And then we have the premotor cortex and the primary motor cortex. So this controls your skeletal muscles for movement. So the premotor cortex is like a motor planning area, and the primary motor cortex has all the neurons for all the different muscles in your body, all programmed in different areas, called the motor homunculus. That's to control your skeletal muscles. And we're going to come back to that in another, my next recording, and we'll show the motor homunculus and talk about how the motor pathway works, with this part of the brain, the basal ganglia, how the cerebellum plays a role, all that stuff, the upper lower motor neurons, and we'll get into that. The parietal lobe has the somatosensory cortex and the somatosensory association area, and that's what's written up here on the top, these top two. So somatosensation is like touch. So all your feelings of pain, pressure, temperature, all those kind of sensations coming into your brain. So like pain is received here. So we'll talk about pain signals later. So if we block the signal from a painful stimulus, whether it's due to actual tissue damage or not, we block it with certain medications like opioids or cannabinoids, or if it's again anti-inflammatory, can reduce the stimulation of the pain receptors. That pain information doesn't get to the somatosensory cortex. We're not going to be even aware of that pain. We'll learn all about that later. So that's what the somatosensory cortex is. So touch, pressure, cold, hot, pain, all that kind of sensation stuff. And then what's an association area? So all the special sensory areas, visual, gustatory, auditory, olfactory, along with somatosensation, have an association area. So the association area tells you what you're sensing and interprets it. So I'm feeling this. What does this feel like? Oh, this feels like a TV remote. I can feel the buttons in my hand and feel the pressure and the textures and all that stuff. Okay. All right, occipital lobe. So visual cortex is back here with the visual association area. So all the visual information. So light comes into your eyes, to the pupils, gets focused by the lens to the retina. The retina has special cells called rods and cones that absorb the light. There's a couple changes that happen. We'll go over all the visual pathway later. But basically, through the optic nerve, that information is carried all the way back to the back of the brain to this occipital lobe. And all the visual information comes in to both hemispheres of the brain. Again, we'll go over the pathway later. And we make sense of what we're seeing in the association area. Keep it that simple for now. Temporal lobe. So we have gustatory for taste, olfactory for smell, and auditory for hearing. They're all going to have their own association areas, even though I didn't draw them there. And then we're going to have Wernicke's area. So the last two areas I'm going to talk about are Broca's and Wernicke's, okay? So Broca's area is near the motor area in the frontal lobe. So this is for motor language. So motor language. So making the movements of our tongue and mouth and pharynx and all that stuff for proper conveyance of language. So speech is just the sounds that come out of our mouth, right? So, but language is communicating to people in a meaningful way. So, but Broca's area is able to actually convey that. Okay. So we talked about Broca and Wernicke's aphasias as well. So with Broca's aphasia, people have trouble with word finding. The words they do say sound fine, and you can and they're perfectly audible and you can understand them. But the video we watched in class, the patient can't get his words out. He goes, it's asked a question. He can understand the question. At first, you're not sure if he can, but then he responds after a long delay. Legs, ankles. So he's understanding what the person's asking him about the pain he's having in his lower extremities. But he just can't get the words out, and he even appears frustrated. So that's more of a pure Broca's aphasia. And we see this with sign language as well. So someone's doing American Sign Language, right, and they don't communicate verbally. Well, if they have a stroke to their dominant hemisphere, to Broca's area, they can't sign properly. So you ask them a question, they might know what you're saying by signing to them, but they can't sign it back. They can't get their hands to do the right movement. So that's why this is language and not speech. So I would make the habit of saying that because I was saying speech, and that's language. So Wernicke's area is by auditory cortex. So Wernicke's area, this deals with speech, language reception. So understanding language, or we say finding meaning in language. So if a patient has a purely Wernicke's aphasia, you saw this in a video in class, when they're asked a question, a couple she understood, but a lot of them she didn't understand when the interviewer asked her to, hey, do this or do that. Had no clue what the person was asking her to do. Okay, but you'd say, well, then they should still be able to make words they're audible, but her words were completely scrambled. We call it a word salad, and she couldn't form meaningful speech, right, or meaningful language. Okay, and this would be the same thing with American Sign Language. They go to sign, and it would just be scrambled signing. Okay, where Broca's aphasia, someone who signs, they won't be able to they'll make a sign, they can't sign something, and they'll have a hard time getting the signs out, but the signs they do get out will make sense. And Wernicke's aphasia, it'll be all scrambled and jumbled, right? And that's a word salad. So to break it down, Broca's aphasia, word finding; Wernicke's aphasia, word salad. If you can remember that, that's at least something you can take away. Okay, the subcortical areas, we'll get through this, that'll be the end of the video, okay? So subcortical brain regions, so the thalamus, so this is important. So basically what connects the spinal cord to the brain is the brain stem. So inferiorly we have the spinal cord here, which is not there. Then we have the brain stem moving inferior to superior, so medulla, pons, midbrain, and sitting atop the brain stem is the thalamus. So all sensory information ascending the spinal cord has to synapse in the thalamus. And the thalamus is the relay center for this information. So everything except olfaction. So the olfactory nerve comes directly back to the cerebral cortex in the brain. It doesn't pass to the thalamus, but all their sensory information has to ascend the spinal cord or brainstem, synapse in the thalamus, and the thalamus will decide where to send it. And some of this information will get sent in multiple places. So we haven't talked about it yet, but when we get to the hippocampus, right, it's sensory linked, or the whole limbic system, I should say, is sensory linked, meaning touch, vision, hearing, smell, all that is going to be linked into the limbic system as well as the cerebral cortex, and we'll talk about that in a sec. Now the brainstem, so midbrain, pons, medulla, so you don't need to know a lot about this, but we have centers here to control our breathing, so all the different respiratory centers like the apnoistic center, pneumotactic centers, a bunch of them, the cardiac center, vasomotor center for blood pressure, so this affects your heart rate, your breathing depth, your breathing rate, your blood pressure, all that. All the cranial nerves are going to synapse here, or most of them. And then all the motor and sensory pathways are ascending and descending up and down through the brainstem because they have to get to and from the spinal cord. Okay. Hypothalamus is a whole other part of the brain. This is part of the limbic system. I put it separately because there's so many things it does. Body temperature is controlled there. Your satiety center for hunger. Remember we talked about osmolarity is assessed there, and antidiuretic hormones made there, but this also stimulates thirst. A bunch of releasing hormones that oversee the thyroid pathway, all the hormones that are overseeing the stress pathway for cortisol, growth pathway for growth hormone, as well as all the sex hormones. So when you go through puberty, you get a big spike in something called gonadotropin releasing hormone, and that's going to cascade all the way down to the gonads and increase sex hormones. All right, now the limbic system. Limbic system is control of the 4 F's: feeding, fleeing, fighting, and reproduction, which does start with an F apparently. And this has to do with survival. Survival of what? Not just survival of the individual, but survival of their genetic code. That's why reproduction is part of this. Reproduction doesn't help you survive, but helps pass on your genes. So that's where this real primitive part of your brain comes from. Even like reptiles have a limbic system. Okay, it's been around a long time. So it's for behavior, and then it really does affect our behaviors because our behaviors help our survival, right? But this is the part of the brain that is important for keeping us safe, but can lead to very inappropriate behaviors if this area is overactive or if our prefrontal cortex is underactive. If that makes sense. There's a bunch of areas to it. We'll talk about just three. There's more than just this. So the hippocampus is there for new memory formation. So if we don't have a hippocampus, we can't form new memories. So there was a patient named HM, famous patient neurology. This patient had epilepsy. They removed both. Epilepsy usually starts in the temporal lobe. In the temporal lobes, okay, because the hippocampus is deep within the temporal lobe, and they removed both hippocampi, cured this guy's epilepsy, but then you couldn't find any new memories. He had his long-term memories, so long-term memories are stored somewhere else. We think they're stored more in the frontal lobe, but all new memories, real short-term memories, are coming into the hippocampus. So this individual had his long-term memories. Oh yeah, in 19 whatever, I went here, went there, I did met this person, or I was born this day and this year, and whatever. But any new memories, you could meet this person and say, hey, HM, I'm so and so. And then 20 seconds later, he'd forget who you are and you have to reintroduce yourself like he never met you before. So alcohol and marijuana abuse can damage this area over time. So alcoholics are people, they're heavy marijuana users, and that can affect your ability to form new memories. And now the hippocampus, so what would memories have to do with your limbic system and keeping you safe? Well, remember, any bad experiences you have or memories growing up as a child or anything like, ooh, if I touch the hot burner, it'll burn my hand off, right? It'll hurt, right? Cause pain, it could damage my body. It keeps you away from unsafe situations, right? You learn those lessons. Well, we better keep those lessons stored in your brain. So that's why the hippocampus is part of the limbic system, okay? And when it does see something that alerts you, well, it's going to send information to the amygdala. The amygdala is the other really big, important part of the limbic system. Deals with fear and anxiety. So if you see something that alerts you from these memories that are stored there, it'll say, hey, you start ding, 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 and the amygdala becomes very, very active. That's how when we study it, that's what happens. We show any kind of a stimulus that would be frightening or scary or something that's dangerous, the amygdala starts lighting up. The problem is if the amygdala is overactive, this is where we get like anxiety disorders, like generalized anxiety, social anxiety disorders. The amygdala becomes overactive with fear and anxious kind of emotions. It gets sent to our prefrontal cortex. The prefrontal cortex should say, hey, it's okay, it's a crowd of people. There's no reason to be nervous or scared or whatever. But the prefrontal cortex can't talk. In your frontal lobe, you can't talk yourself down because the amygdala is so overpowering. And that's when people have like anxiety attacks. Same with PTSD, so post-traumatic stress disorders. So that trauma, those memories and trauma are embedded in the limbic system. And then when something is sensed, remember this is why all the senses are linked into the limbic system. Someone sees something, hears something, smells, tastes something, touches something that reminds them of this traumatic event. They can have a panic attack or have some real bad, emotional stress. So that's how that works. So it's good if it's working at a normal level, just to keep you away from doing dumb stuff and keeping you safe, okay? But if it's overactive, it can lead to a lot of difficult problems. So the hypothalamus, so this deals with feeding, right? So in thirst, we already talked about that on the left. Reproductive behavior, because remember, you go through puberty, you get a spike in this hormone called gonadotropin releasing hormone. That stimulates the anterior pituitary to release two hormones called luteinizing hormone, follicle stimulating hormone. Those are going to travel to the gonads, so ovaries in females, testicles in males, and increase sex hormone production. Okay, sex hormone production has all kinds of effects, like going through puberty, secondary sex characteristics. But those hormones are also going to cross the blood-brain barrier, go back into the brain, and affect our reproductive behavior. Okay, so men and women all have testosterone and estrogen levels, but just in differing amounts between males and females. But again, levels of those hormones are going to affect reproductive behavior, okay, and sexual behavior. So the amygdala is more for fleeing and fighting, and then the hypothalamus is more the feeding and reproductive part, okay? But remember, all this is going to send information to the prefrontal cortex. So this is all subconscious. We're not technically aware of this, but the information is getting sent to our frontal lobe. Then we will be aware of this, right? But sometimes we get these strong emotions we can't control, or these thoughts we think that we're not in quote-unquote control of our thoughts. Well, we're going to have inappropriate thoughts because that's just how this part of our brain works, right? Aggressive thoughts, violent thoughts, even sexually inappropriate thoughts, but the prefrontal cortex is there to control our impulses, okay? So this part of our brain is very important for human behavior. Now, the last part we'll talk about is the basal ganglia. This will come up later. We talk about the movement in detail. So this has a large concentration of dopaminergic neurons. It has multiple parts: the putamen, caudate nucleus, globus pallidus, substantia nigra. We looked at the sections of the brain. It was some of these areas of deeper gray matter in the brain, okay? And these are important for movement. And I'll just say this for now, they refine movement. They have their own descending pathways down the spinal cord, and they make sure movements are smooth and coordinated. Not coordinated, it's just nice, smooth, well-refined movement. So, and we only realize this when people have damage to these areas of the brain. They have low dopaminergic activity. What happens if they lose these dopaminergic neurons? They start getting movement disorders, either tremors or rigidity, or sometimes weird like writhing movements. And we see this in Parkinson's disease. We watch videos of some of the Parkinsons. They're very stiff. They have no arm swing. They have a shuffling gait. They have a mask-like face, or people call hypomania, and they get a resting tremor. And the other disease we looked at was Huntington's disease, which is a genetic disorder, and these people get writhing movements and they're moving around and they can't control their voice very well, and it's really, really bad. So this is just important for refining our movements, but we'll talk about that later. Okay, so this is it for the first lecture for your first quiz.